Good morning, everyone. It is a part of the body you don't normally get to see. The colon. You are looking at an inflatable, interactive model of the human colon. This morning, we are going inside to show you how this part of the body helps our digestive system, but this part of the body is also prone to cancer. And one genetic disease called Lynch syndrome could be the culprit. The morning medical update starts right now. It's Monday, March 21st. Thank you so much for joining us right here on Facebook, on YouTube, and on Twitter. 1 in 300 people have what's called Lynch syndrome. It's hereditary, and it could lead to colorectal cancer. Surgical oncologist Dr. John Ashcraft is back with us today on how common this is and how to find out if you have it. And last time he was here, he wasn't too happy with me because I went 2 years past my colonoscopy screening, so I've got a little update for him. Can't wait to share. Plus, we're going to go inside that gigantic inflatable colon. That'll be pretty fun. So let's take a look at that right now. Let's get right to it, where Alexis Del Cid is joining us live today. I know, Alexis, you've reported in a lot of places across the country, but this might be a first for you.
Yes, it's definitely a first. I've never reported inside a stolen colon before. And yes, I said stolen colon because this is the original stolen colon. We're going to get to the backstory in that a little bit later in this broadcast. But first, let me show you how cool this is. This is really neat. A little bit about the colon. Inside you right now, you might not know this, is 5 feet of colon. Every person has that. When you eat food, it takes 12 to 48 hours for that food to travel through your colon and make it out. When you get a colonoscopy, though, it only takes, anywhere from doctors say, 30 minutes to 2 hours, depending on what they find. We're going to check back with you in just a little bit and tell you how they're able to use this giant inflatable colon, the doctors and the people here at the University of Kansas Health System, as a fantastic teaching tool for the community. We're going to show you what you can learn by looking at the various displays inside this inflatable colon. And yes, we're going to tell you the backstory of the stolen colon. That's all coming up later on in the broadcast.
We can hardly wait. Alexis, thank you so much. All right, let's get to this morning's medical headlines. The number of deaths in the U.S. involving alcohol jumped 25% from 2019 and 2020. That is the first year, of course, of COVID. The research published in JAMA found there were more than 99,000 alcohol-related deaths. Experts say it's important for doctors to ask patients why drinking has increased. Students and staff at the University of Kansas no longer need to wear a face mask in class. The change, starting today, applies to both the Lawrence and Edwards campuses. KU began its phase out of the mask requirement on March 3rd with the removal of the requirement in non-classroom settings as COVID cases began dropping to pre-pandemic levels there. And the TSA handed out more than $640,000 in fines over this past year for people violating the face mask requirements on planes and in airports. The nearly 1,000 fines handed out ranged from $630 all the way up to $3,100. Get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You can find links to those right here on your screen. Now, let's get to Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, joining us on this Monday. How you doing? Good morning.
I'm good.
Let's get to some numbers.
My daughter's birthday's coming up. I think instead of a bouncy house, I'll rent the stolen
There you
colon.
go. I know.
That'd be good.
Exactly.
Have cake in the stolen colon.
Exactly.
Again, we are seeing down trends of cases, hospitalizations, and deaths all across the country from COVID-19, so that's a good thing. Currently in our hospital, we have 14 active infections with 2 in the ICU, 1 on the ventilator. 49 in that recovery period. Our last COVID death was on the 24 hours on March 27th. So that brings our total for March to 16 deaths from COVID as of today. So
all right.
We are still seeing it, unfortunately, but hopefully we can keep that trend as low as possible.
All right, let's check and see if we have any reporters on the line today. All right, moving on this morning. March is Colorectal Cancer Awareness Month. We've already learned it is affecting people younger and younger. But today we discuss a hereditary gene that increases your chance of developing colorectal and other cancers. Joining me now here in studio to talk more about that is Dr. John Ashcraft. Good morning to you. Good to see you.
Good morning. Good to see you again.
All right. So let's just first of all jump in and talk about what is Lynch syndrome.
Yes.
Many may not have even heard of that.
Yeah, so Lynch syndrome is one of the many ways we can get colon cancer. When we look at colon cancer, 75% of all colon cancers are what we call sporadic. We can't find a reason. We don't have a genetic cause. They just are an accumulation of problems. The other 25% we can find a cause, and one of the biggest of those causes is called Lynch syndrome, which is an inheritable form of getting colon and rectal cancer. Normal patient population might be around 8% chance lifelong of getting colon and rectal cancer. These patients run 30 to 40%. And we know that that can be sent down to their children and their progeny, and so it's important that we find it and identify it if they have it.
So how do you know? How do you know? Do you get screened for this? Is it important to know your family history? How would one know?
So it's a great question. So there's two real ways that we do it. One way is by looking at your family history. We can look at the number of people that have had colorectal cancer at a young age in your family, or the number of people who have had colon and rectal related cancers in your family. The other way we can find it is by looking at the tumor directly. We here at the University of Kansas do a battery of tests on every tumor that we identify, and if we see certain genetic deficiencies in those tumors, then we recommend the patient go see a genetic counselor and obtain genetic testing for that.
Let's talk, what's cascade screening?
So cascade screening is, for anybody who took genetics back in college, it's when you draw the entire family tree of a patient. And it's important because, like I said, one way you can identify if somebody has Lynch is by looking at their history, looking at how many of their family leading up to that patient has gotten colorectal cancer or a colon and rectal cancer related cancer. But also, if you can identify that patient, that one person, then you can look at their offspring, and you can cascade down the family to identify the people that have the genetic defect. And once you know you have it, then you can screen more appropriately.
Would there be any signs that would show that you have Lynch syndrome?
No, the signs, other than the normal signs that we talked about last time, bleeding, change in bowel movements, weight loss you can't explain, things like that, those would be the signs you want to look for. The trick with Lynch is that it shows up at a much younger age. We typically see it in the patients way less than 50.
And is it only related to colorectal cancers?
No, there's other cancers that have been associated with it. Endometrial cancer, stomach cancers, some related to ovarian cancers and things like that.
All right, so what lifestyle risks do people need to watch out for in general when it comes to colorectal cancers? Let's dive in.
So it's interesting that we can't really tease out specific ones, but we can get some that are related. So ones that we want to watch out for are a high-fat diet, low-fiber diet, high-red meat diet, high-processed food diet. We know that those diets can increase your chances of getting colon and rectal cancer. And of course, smoking, obesity, those things play into it as well. Having a sedentary lifestyle, being active is really important. And so those are things that we can prevent and we can control for. You can't control for your family, of course, but the things you can control for, you should try to.
But it goes to show how much diet activity really just ties back into all aspects of our health, right?
Yes, ma'am. Yes, ma'am.
Okay. I want to ask you some more questions, and we've got some really good ones coming in. But let's go back to when you came back on here the first of the month. You kind of eyeballed me and shamed me just a little bit, and I deserved it because you had asked if I had had my colonoscopy screening. You asked how old I was. And in that case, it was okay that you asked how old I was because I was 2 years past when I was supposed to have it. You're supposed to have it at 45. I'm 47, so I was 2 years past. And you said, when we get done with this show, I need you to schedule your colonoscopy. So last Monday, here's what happened. Hey guys. Okay, so it's 2 years past when I'm supposed to have had my, what is it, Laura? My screening colonoscopy. I'm 2 years late, and Dr. Ashcraft called me out on it. So I'm here to just tell him I'm here, I'm prepped, I'm ready, I did it. We're about ready to go back here in just a few minutes, and you said it's just going to be a nice little nap, and I'm going to wake up, and they're going to tell me what's going on up in there. So I'm a little hangry. That's about it. I haven't eaten since, it's Monday around 10:30, and I haven't eaten since Saturday evening, so I'm a little grumpy. But other than that, they're being so nice to me, and they gave me a nice warm blankie. So, and look at my beautiful socks. And hopefully I get to keep these.
Okay, that was like such a good nap. I could hear you guys talking, and I thought it was my kids talking.
It doesn't sound like a good nap.
I was like, why are my kids here? I was like, that's not good. And then I looked over and I thought one of the nurses was Alexis, and I was like, why are you dressed as a nurse? Okay, so they're going to bring me crackers and Sprite. So it's the first food I've had since Saturday. So it's going to be the best meal ever. And Laura is back with me again. So everyone's been taking such good care of me. And the minute I woke up, within 2 minutes, Dr. Rastogi was back to tell me that everything looked good. So I'm doing well.
Are you proud of me or what?
I am so proud of you. Thank you so much.
No, thank you. I appreciate you doing. I honestly, had you not have been on the show, I probably would have just. I would have been in the back of my head to get my screening, but I don't know if I would have been like, this expert just told me I need to do it, so I better do what she said.
No, you really do need to do it, and now I just found out Dr. Hawkinson needs to do it.
I do.
You're up next, friend.
I'm looking for the next few weeks here when I'm off service. Yeah.
Okay. And then we're gonna get some video of you.
Oh yeah.
Oh yes. I think you said you would do.
I'll do it.
Well, you can do it. I trust you. You're an expert. You do excellent work. I would trust you for sure. But there's going to be no video.
Okay. Well, here comes. Okay. I don't know who talked me into this, but I brought along some photos. Okay.
I love it.
And hey, after you've had a baby, I don't really think it matters at this point. So let's just get on in there. Okay, people. Okay. What are you looking at? Okay, this is the inside of my colon, people. This is the Katie Couric moment that Dr. Hawkinson has been waiting for me to do.
House.
How's it look?
It looks good. So first thing is AJ and I would notice, Dr. Bansal, who you talk to in a minute, is you did well on your prep. You're nice and cleaned out.
Yes.
And, you want to see that smooth lining, nice pink color to it. You don't want to see any tears or redness or bleeding or anything like that. You don't want to see any masses or growths. And the fact that Amit Rastogi, who is an expert GI physician, he would have found those things if they would have been in there. And so it's great that you had a clean bill of health, and I'm proud of you.
Thank you. And he said because he didn't see anything, I was thinking I'd have to come back in 5 years, but he said I don't have to come back in 10 years, but maybe he was just trying to give me some good news.
No, he's right. According to the guidelines, you do not need another colonoscopy for 10 years. I may not agree with that number, but...
you wish it was sooner. You feel like 5 years.
I do. But what I would say is 10 years for a routine screening, but if you notice that you're having any bleeding, any change in bowel movements, sooner.
Okay, you got it. I'm listening to you. Okay, so I think we want to let's get out to Dr. Banzal. I want to get out to Alexis. And you both are now, you have a friend now standing inside the stolen colon.
Yes.
What's going on?
This is incredible. Well, Jess, first of all, I know you so well now. This has been
Right?
such an adventure. Right. Hats off, though. It's so important, and it's so great that you're sharing with people what the process is, because sometimes people don't want to talk about it, and we really should. It's so important. I'm here with gastroenterologist AJ Bansal. We're here at the entrance of the inflatable colon, and I want to talk to you a little bit about what you look for when you're doing a colonoscopy, because you use a special scope so you can traverse the whole colon. What do you look for when you first get in there?
So thank you, Alexis. It's a pleasure to be here. So when we do colonoscopies, obviously the first thing when we enter the colon is to look at the quality of the prep. And that's where the patient's input comes in. So one thing I urge my patients to do would be to follow the instructions carefully so the colon is nice and clean. And then once we get to the end of the colon, which is 6 feet long, we, just like John Ashcraft said a few minutes ago, we look for a nice healthy lining in the colon, which is nice and pink.
So that's normal tissue.
That's normal.
And then what are these, and what do you look for with a polyp? They're just bumps like this?
Exactly. So these polyps, think of these as moles on the skin. So these are kind of moles inside the colon. These are raised moles, but they can also be what we call flat polyps, where they're much more flat and they can't be diagnosed by a regular colonoscopy, or they may be missed by a regular colonoscopy, and that's where we use the special light.
Now, Dr. Bansal, we're going to go further into the colon, but I want to go back a little bit to the very beginning of this broadcast when we talked about the stolen colon.
Yes.
This is the colon that was stolen about, what, 3 years ago?
Correct.
You were here. It was an historic event
Yes.
for the colon that we're
It
in
was
right
covered by
now.
the New York Times.
It was, and we want to show you some of the other national coverage that we got here in Kansas City after the colon was stolen.
A giant inflatable colon was stolen in Kansas. Yes, the 10 by 12 foot colon is actually a tunnel, although in a sense, that is true of all colons.
So that was quite an adventure to hear that. And it was so funny to people, but it was recovered.
Right.
I guess the person who stole it, police had thought they'd stolen some tools or something.
Right. And I don't think I ever heard about the motive, but maybe
Right.
just for a
The
birthday
motive.
party. Maybe just for a birthday party, a 50-year-old birthday party.
Right. And they thought they were maybe taking a bounce house
Yeah.
or something. This is far more interesting than that. Dr. Bonsall, I want to now continue on our journey through the colon. It's a serious topic here. We're having some fun with it this morning, but it's so important to show you guys at home what you're seeing here. Now, these are malignant polyps.
Correct.
So what's the difference between these and what we saw on the other side?
So this is what we are looking for, and this is what we are trying to prevent. So what happens is, when you have colon cancer, it doesn't occur overnight. It happens over many years, where a small polyp turns into a malignant polyp and then eventually into cancer. And that's why colonoscopy prevents cancer, is because we can find the malignant polyp or the polyps before they turn into cancer and remove them.
And you can also find other things like signs of Crohn's disease. So what are these that we're seeing here?
So these are ulcerations in the colon. So Crohn's disease is an autoimmune disease like lupus, where it can cause ulcerations in the colon. So yes, we can see those.
If someone has to have part of their colon removed, you can live without a colon. How does it change your life if you have your colon removed or part of your colon removed?
That's another great question. So the colon is 6 feet long. So for the most part, if you're part of the colon removed, the other part of the colon can take over and the cells can grow to do the same function. Typically, we do see increased number of bowel movements, but which we can control with increased amount of fiber, change in diet. So most patients do exceptionally well after any surgery of the colon.
But you can go on to live a pretty
Oh, a
healthy,
normal
normal life.
Yes.
What are some of the proactive things that we can do right now in our own lives? Like, what are the worst foods to eat that will irritate your colon the most, and what are the best foods to eat?
So the best foods to eat would be fruits and vegetables, clearly, and greens. So there was a beautiful study done in UCSF in which they looked at patients, how much color patients have on their plate. So when you eat, make sure you have 4 different colors on the plate: some broccoli, some meats, some cauliflower, some carrots. And the study showed that when somebody has 4 colors on the plate, then they're doing a good job with their diet. And things to avoid, which we don't completely understand, obviously, but one of the main things is processed food. So clearly, when you have preservatives and processed food, it changes the way the microbiome in the gut behaves. That can cause inflammation and increase the risk of cancer, but we still have long ways to go before we precisely understand how that causes cancer.
I've heard the diet that you're talking about called the rainbow diet by some doctors, because you're supposed to have every color of the rainbow. What about cleansing your colon? Is there a way to do that from the liquids we drink, or a colonic? I've heard of people getting colonic. So what's your take on that?
So that's a question which comes up commonly in my clinic about colonics. So there is some reason to do it, but I don't recommend it, because so what colonics do is they are supposed to reset the microbiome in the colon by removing the microbiome which is there and replacing it with the new one. But what happens is we don't really have any studies or any clinical trials showing it works. I have seen complications because of it. I have seen perforation of the colon because of it. So definitely I would strongly advise to avoid it, at least for medical purposes. You may want to have other kinds of fun, but that's different. And high colonics, eventually we need to study them properly, but indirectly by changing the microbiome of the colon.
When we get to the end of the colonoscopy, as far as the camera will go, what are you looking for at the very end?
So the very end of the colon is part called the rectum, and the cancer of the rectum behaves very differently from the cancer of the colon. So we are looking for rectal cancer so we can be more aggressive treating it. Also, we're looking for hemorrhoids, anal fissures, and other things at the end of the colon to make sure there's no other explanation for bleeding.
So, okay, interesting. I was thinking when you started at the beginning, that's the first thing you look at, but that's the last thing you look at when the cameras come on the way out?
Exactly. So
okay.
So that's something which, so the beginning and the end are different for us. So when we first get inside the colon, our goal is to get to the end of the colon, which is 6 feet long.
Okay.
And then when we are withdrawing the scope through the colon, that's when we slow down and look carefully at all the folds, at the lining, at the end of the rectum, the colon, to look for cancer, polyps, hemorrhoids, anal fissure, Crohn's disease, many things.
Okay, and that takes anywhere from, I've been reading a lot, about 30 minutes to 2 hours, depending on how involved the process is.
So that's a little longer. So most colonoscopies, when we are looking for polyps and cancer, typically take anywhere between 10 to 20 minutes.
Okay.
But if you find early cancer or if you find a big polyp to remove, then it can take longer.
Got it. This is fascinating, and this really is a great tool. And you take this to places across the community. The health system will use this if a school requests it, or if someone wants to request it for any kind of event. This is it arrives in a big tub. When we arrived this morning, guys, it was just sitting in a tub. It could have been anything. It could have been a tarp. It could have been a box of tools. It was this huge inflatable colon, and it goes everywhere. This is really cool. Dr. Bonsall, thank you.
Thank you, Alexis.
Jess, I'm going to toss it back to you, and we'll check back in with Dr. Bonsall in a little bit.
Okay, let's do it. Very cool. Great insight today. Thank you both. All right. Anything you have to add to any of that? Just, I want to talk a little bit about the prep, because a lot of people are concerned about the prep. That always gets a bad rap.
Yep.
I think the hardest part for me was just the not eating, because I'm kind of an eater. So, but that might not bother a lot of people. But you know, the prep has changed. I had a colonoscopy probably 18 years ago, and I don't remember the prep has changed a little bit. So, but just how important is it? You said, and that was the first thing you had mentioned, and so did my doctor Rastogi. Also had mentioned how you did a really good job.
Yes.
How important is it to make sure that people really follow and stick to the pre-prep?
It's incredibly important. If you don't prep well, then we can't see the lining, and that's what we're looking for, is that lining of the colon. And if your prep is poor, then we can't see the lining. Despite any maneuvers we may do with irrigation and washing and trying to do stuff while you're asleep, sometimes the prep's just not good enough. And so in those patients, we have to wake them up, bring them back a few days later, and actually have them do a 2-day prep instead of just 1 day. And so it's important, like Dr. Bensel said, is follow the instructions, do them as best you can. Stick to clear liquids for those days before, or that 24 to 36 hours.
Right.
And don't eat any solid food, stay away from red Gatorade, things like that. Because you want you really don't want to go through it again, right? And so do the best you can, get it done, and then
because I am definitely one of those people who would have probably tried to cheat or sneak a little something in. I admit I'm one of those people. But the gal on the phone who prepped me said, don't do it, because then you're going to have to go back and do it again. And that is the last thing you want to do.
Of
so
course,
I did. I was scared into doing it right. Okay, question from Deb this morning. Let's get to some community questions, shall we? Deb wants to know, is red meat harder on your colon than other meats like poultry?
So we know that red meat, a high red meat diet, does increase your risk of colon and rectal cancer. To say whether it's harder or not, I don't know that for sure, but we do know that there's an association between red meat. I've never seen anything related to chicken or pork or any of the other fish and things like that, so I've never seen any data related to that. There is some data about smoked meats in terms of increasing cancer risk for certain cancers. So all in all, I would go back to what Dr. Bansal said. A good, well-balanced diet, lots of fruits and vegetables, that's going to be your key.
All right. Isaac wants to know, following a colonoscopy, is there a lot of lingering pain in the area operated on post-surgery? I know, he said, I know when I got my wisdom teeth out a year ago, there certainly was. I know for me, I didn't know a thing had happened. So that's good news. It is.
So there used to be, when we initially did colonoscopies way back in the day, we would use straight air, which would leave patients really bloated, and they would have a lot of gas pains and a tremendous amount of difficulty with that. But now we use CO2 gas, which is readily absorbed, readily expelled. And so most patients, much like Jess said, you wake up, you don't even know you had it.
Joe Ellen wants to know, in researching family history, I discovered a great uncle had colon cancer on his death certificate. How close of a relation would that be considered a risk for her?
It's something to keep in mind. That's a pretty distant relative. I don't know that would raise too many alarm bells if you were seeing me in clinic. But you want to keep track of your family as best you can, because the more family members that you can see, that might go into that cascade analysis that we talked about, that we can look to see, is there something genetic in your family to watch out for. Knowing your family history is important. We know that family history is probably we talked about risk factors and we talked about diet and stuff like that, but we can't forego the importance of family history. Having one direct family member can increase your risk by about 2-fold. Having 2 direct family members will increase you by 4-fold. And so those are significant risk factors.
But it's smart for her to be looking into that and
Yes.
asking questions. I like that. Dr. Hawkinson, I do have a couple of COVID questions for you. Elena wants to know, I recently found out I'm significantly iron deficient. Because of that, my platelets are high. Does that put me at higher risk of clots if I catch COVID?
You know, I don't think there's any data to support that. Just the higher number of platelets, you'd also have to look at their platelet function, but I don't think that's going to increase your risk. I haven't seen any data to support that. Obviously, if you do have any, abnormal cell counts, whether they're too high or too low, you can be at risk for different things, but I haven't seen anything that is specifically going to say that you're going to be at higher risk of clotting with COVID-19, which we know does increase overall risk of blood clots, both large and small.
And Carol wants to know, she'd like to hear about the progress of the BA2 variant. Any projections about its growth and prevalence?
No, I was just looking at the CDC, their forecast or nowcast, what that is. We know that the prevalence in the United States is growing, somewhere up to 30% or more in some regions. But again, we don't have very good publicly shown data to support that. We know our sequencing data is a little bit behind, but we do know that the prevalence of BA2 is increasing, and we know that the FDA now has pulled the emergency use authorization for sotrovimab, which we were able to use against Omicron. That's one of the monoclonal antibodies, but now because that prevalence of BA2 is a little bit higher, there is that risk that if you use sotrovimab, it won't work, so they have pulled that. We have not been using sotrovimab now for a week and a half or 2 weeks here at the health system. So we do know those the prevalence is increasing, but overall we still are not seeing a large increase in cases, thankfully.
Couple more quick questions, Dr. Ashcraft. Joellen wants to know, how can I avoid nausea during the prep? And I have to say that is tough because you can't eat solid foods going a couple of days or even a full day without eating. I know I was eating bone broth and things like that. It was helping a little bit, but anything else that and I was able to suck on some hard candies.
That helps, yeah.
That helps. Anything else you're able to do?
So there's some small tricks. Much you mentioned sucking on hard candies. Ginger drinks have been shown to be a benefit. The probably thing I'd mention most is just be in communication with your provider. I have many patients who call me and say they're not tolerating the prep. We're having difficulty with nausea and vomiting. And I will prescribe them an anti-nausea medicine so that just to get them through it, because like we said, that prep is important. You don't want to go through it again. So get it right the first time. And if it means getting you some anti-nausea medicine, that's what we'll do.
And a lot of people have headaches if they don't eat. I know we were told to take Tylenol, so I had to do that too. But, just rough it out a little bit. It'll be over soon. Sean, last question. Sean wants to know, is there an older age where you stop recommending a colonoscopy? What is sigmoidoscopy? It's a big word. I don't do those. But did I get that right?
Sigmoidoscopy.
Sigmoidoscopy. And do you recommend it instead for elderly patients?
So those are actually phenomenal questions. It's very difficult to put a cap on when you say you should stop screening patients. And the whole idea is the risk benefit. If you screen an 80-year-old and their colon might be a little bit more friable and risk of perforation and things like that. And so you want to be cautious in the elderly. But the thing I always think about is not every 70-year-old is every 70-year-old. Some 70-year-olds that behave like they're 50 and act like they're 50 and look like they're 50, and some are more like 90. And so I take it on a case-by-case basis. There is some information out there that says somewhere between 70 and 75 we should stop doing elective screening colonoscopies. But again, I think most of the people that I know would say look at each patient individually and take it on a case-by-case basis. Now, there's lots of ways to watch the colon. The best is the colonoscopy. We love that one by far because you can see the entire colon. Some people will say, well, let's do a flexible sigmoidoscopy, which will go up and look at maybe 20 to 40 centimeters, which is not that far in a 5-foot, 6-foot colon, right? But you can catch maybe 60, 70% of some cancers depending on how it looks and how far they can get around with a flexible sigmoidoscopy. And some people do it without anesthesia as well, and so patients tolerate it usually very well. But again, the gold standard is a colonoscopy, a full colonoscopy.
Okay, I do want to sneak in a couple more questions. Fanny wants to know, how does she go about setting up a colonoscopy? Do you accept Medicare for that procedure? She said her brother died of colon cancer. How often should she get that procedure? Kind of along the same lines.
Great question. So, yes, we accept Medicare and Medicaid at the university. You can call the GI department and they would be happy to schedule you for a colonoscopy. Your family history is extremely important, and it's hard. Everybody wants to know, how often do I get a colonoscopy? How often am I going to need this? Much like with you, Jess, it was when you come out of it, the big question is, what'd you find? And that of course is the answer. Is it really depends on what they see on the colonoscopy. If on the first colonoscopy they see nothing, then they may do exactly like this and say 10 years. But in your case, you have a family history, so I imagine they're going to bring that back a little bit, maybe go 5 years. But if they saw polyps, depending on how bad the polyps were, did they get them all out, how big they were, they could bring you back as soon as 1 year.
Okay, I had not heard of this, but why do some doctors allow PrEP with Crystal Light or Gatorade and laxatives versus prescription PrEP? She said she's used both, and the laxative PrEP is much easier to tolerate, I would imagine. Is that something that somebody would be eligible to do?
Sure.
I kind of want everyone to have to go through what I went through.
Why?
I want them to have to drink everything that I drank.
There are lots of PrEPs out there.
Okay.
There are literally dozens and dozens and dozens of ways of cleaning out somebody's colon. No one PrEP works for everybody. We have to kind of curtail it to the patient and their history and their medical conditions. And so every PrEP is a little different. Every patient's treated a little different, and every provider uses their PrEP that they're most comfortable with. And so just communicate with your provider. They'll get you through it.
All right, last one. Joe wants to know, my dad died of metastatic colon cancer, but he was an only child, so there's not a lot of family history there. Neither of her grandparents died or had been diagnosed with colon cancer. Other than genetic testing, how would I know my risk? Or is that a risk if a parent?
Yeah, a parent is that
died?
direct family member,
yeah.
and so that would be that's a huge one, twofold increase in risk with this person. And so I would recommend that you get your colonoscopies. You need to know the age at which your direct family member was diagnosed, and then we'd recommend 10 years sooner than that. Typically, if they were diagnosed at 50, then you would start your colonoscopies at 40. And again, that's routine screening. If you have bleeding, if you have change in bowel movement symptoms, we would do it sooner. And so knowing your family history is of importance, and you need to be really watching yourself, especially with that history you described.
All right, thank you so much for coming back.
Oh, it's my pleasure. Thank you for getting your colonoscopy.
You bet. Doctor's orders. Okay, so let's get to some final thoughts, and I'm just going to let you lead us on.
Get your colonoscopy. It's important. We say it all the time, and you hear us talk about it, but much like Dr. Bonsall said, we can catch it early. We can prevent this. This really is a preventable disease, and it's the number 2 killer in terms of cancers, and we can really prevent it if people will just get their colonoscopies. It's not that bad.
All right. Dr. Hawkinson, your final thought is going to be what? When are you scheduling your colonoscopy?
Yeah, I think probably in a few weeks here.
Okay,
so it'll
we'll
get
be
done.
waiting.
Again, I think the message continues to be prevention. Prevention is the best. We know that during the time of the pandemic, screenings for breast cancer, colon cancer, all of those things were reduced, and we're seeing higher rates of cancer in those later stages because of that. So it is greatly important to go get screened. Certainly I'll be signing up for mine soon here. So prevention is the best. Prevention with screening, prevention with vaccinations, not only COVID vaccination, but make sure you're up to date with your other vaccines as well. And I think that's continues to be the message. It's a lot better to do those things up front than have to deal with the consequences after that.
Well said. All right. Alexis, I want to check in with you. One of our viewers' comments this morning is Delane says that Dr. Banzel is awesome, such a wonderful guy. So please tell him thank you for going on this journey with us.
Oh, well, Delane, you just did. He has an earpiece in, too.
Oh,
good.
And this has been. You have some fans.
Yes, he heard it. So that's wonderful.
Thank you. That's great to hear.
And it was such a pleasure to talk to you today and have you guide us through this. And, your colleague had such a good point. You don't want to do the PrEP twice. Do it right the first time. And that's something that you have stressed as well. The PrEP is kind of the worst part.
Right.
Colonoscopy is like you're taking a nap,
right?
Right. So what would be your message to viewers like Delane who are watching and other people who had such good questions today?
So I will make 2 points to make sure that we decrease the incidence of colon cancer. One is do the test which works for you. So the best test to prevent colon cancer is the one which gets done. So there are at least three different ways of testing for colon cancer. Colonoscopy obviously is a big one because of all the tests for colon cancer, it's the only one which can truly prevent cancer. But we have other tests in the stool where we look for blood in the stool, or we look for DNA in the stool, which can help us diagnose colon cancer and maybe a few polyps. So the best test is the one which gets done. So pick one of these and get screened. And my second message would be, as Dr. Ashcroft mentioned, about the family history. So know your risk. So know who in the family had colon cancer, younger age, how many family members, and then talk to your primary care so we can do genetic testing to diagnose syndromes such as Lynch syndrome, which can really help us figure out your colon cancer risk, and we can accordingly increase or decrease the number of colonoscopies.
Dr. Bonsall, thank you so much.
Thank you.
This has been fascinating, and it's actually really cool to finally see the colon in person, the stolen colon, back at its home where it belongs, guys.
That's right. All right. Thank you both for taking us on that journey today throughout the colon. All right. March 30th is National Doctors Day. And here's a way to say thank you to all healthcare workers. Many of you ask how you can show your gratitude. Well, here's how you can do that. There's a QR code right there on your screen. Just open your camera and hover your phone right over that, and it's going to take you to an email. You can send a nice note or a 30-second video, and then we can share them right here on air. And Linda Homan did that. She sent in us a nice note that we wanted to read here. This is really to Dr. Hawkinson, Dr. Ashcraft, Dr. Stites, all of the experts that join us here every single day. She said, "Thank you for continuing these informative programs I've been watching continuously since the beginning. The information you provide was especially important at the beginning of the pandemic as you were, quote, building the airplane," as we continue to say here. Thank you to all connecting us in this program and all the dedicated healthcare workers. So thank you, Linda, for sharing your words with us today. Thanks for watching, too. And before we go, congrats, of course, to the Kansas Jayhawks, who are now Final Four bound, as it should be. Take a look at the celebration on the streets of Lawrence yesterday after the team won in Chicago after beating Miami in the Elite Eight. In fact, police had to shut down the main road in downtown Lawrence because of the fans there. Well, doing what they do, and they're celebrating the Jayhawks.
Baby, yeah.
So they play Villanova Saturday night, and we will be watching. Thank you all so much for being with us today. Don't forget, you can catch our shows anytime on Facebook, on YouTube, and of course now on Twitter. Tomorrow, spring is here, and more of us will be out running. Not me, of course. The Boston Marathon is on its way, just a few weeks away. It is the official or the unofficial start of marathon season, and many runners, including high school teens, are getting a head start.
It's really helpful because it shows me my form and tells me what I need to fix.
How to prep and the tools available to improve your running game. This technology was a game changer for this team. We'll tell you how. We'll see you tomorrow at 8.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.